Hello, everyone. You are at the Silver Hill Hospital Grand Rounds program, and people are just joining. We'll get started in just a moment. Thank you for being here. All right, everybody. Hello and welcome. Thank you again for joining us. I'm Dr. Jeff Katzman, Director of Education here at Silver Hill Hospital. We are absolutely delighted to have you join us. This week celebrates National Nurses Week, so a very, very special warm welcome and much gratitude to all our nurse attendees out there. We send you our appreciation and hearty thank yous for all you do at Silver Hill Hospital and for the community and wherever you are. Today, we are extremely privileged to welcome Dr. Kathleen Delaney, who will present to us on the topic mitigating workplace violence, turning challenge into an opportunity. And I have the absolute pleasure of introducing her in a moment. First, a little housekeeping. Our next Grand Rounds is on May 22nd, when we welcome Dr. Claudia Gold, who will present to us on the topic of the power of discord, a relational model of mental health care rooted in the developmental science of early childhood. And she's one of the pioneers of the still face, and her book with Ed Tronick, The Power of Discord, is based on that model. So we hope you can join us. It's a nice opportunity for us all. For Q&A today, I'm joined by Dr. Immaculate Khan, our Chief Nursing Officer here at Silver Hill, who will help co-moderate a question and answer discussion with Dr. Delaney at the conclusion of the lecture. This is really a great opportunity to put forward questions and comments to Dr. Delaney, which you can submit anytime during the lecture by using the Q&A link. And I know that we have a whole group in our Martin Center watching together. So if anybody has a question from there, please get that to the person who is running technology, and they can input the question in the chat. If you wish to receive CME or CEU credits, please complete the evaluation survey that will automatically show up in the browser when we end the webinar. We will also email a copy of the survey to today's participants. And finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME defined commercial interest. And it is now really a pleasure for me to get to introduce our guest speaker, Dr. Kathleen Delaney. So throughout Dr. Delaney's career at Rush College of Nursing, she has really blended an academic and clinical and research roles. Her clinical work focused on child mental health, particularly developing the theory base of inpatient nursing care. Her funded research centered on creating safe and healing psychiatric environments, and her professional service involves mental health workforce research and projects developed with the American Psychiatric Nursing Association's Council for Safe Environments. Dr. Delaney has authored policy and position statements on child mental health, the mental health workforce, and most recently on workplace violence. She is currently a professor emeritus at Rush College of Nursing. So, Dr. Delaney, what a pleasure to get to welcome you to our program, especially during this celebratory week. And when we're sending well wishes to all the nurses who are attending our program. So thank you again for being here. I pass the baton to you.
Thank you very much for that very generous introduction. And it's my pleasure to be here and to speak to such a crowd of skilled clinicians and providers, and it's really my honor. As Dr. Katzman mentioned, I have no disclosures to report. I have three objectives that really map out what I'm going to talk about today. So I'm just going to go over them so people understand the kind of direction we'll be going. The first objective is to discuss an alternative focus for worksite analysis related to violence. And with that, the utility of patterning health service factors related to violent incidents. Then I'm going to talk about how violence reduction strategies, my prime such a preoccupation that the the focus of risk aversion supersedes the focus on engagement. And finally, I'm going to describe the impact of organizing staff work around risk reduction if we hold on to a belief in preventable harm. So we'll see. We'll see how we move through. I think that all of these statistics are well known to the audience, unfortunately. We have healthcare violence has been in the news, so we understand, especially from the Bureau of Labor Statistics reports, that we're getting 4 times as many reports in 2020 as compared to 2019. We know that both psychiatric and emergency departments are the most common sites. As a matter of fact, according to the BLS, 10 times higher on psychiatry than general hospital. We also understand that the rates of reported assaults against nursing broadly are increasing, up 5% in 2022. This is recent Press Ganey data, which they released in a general report, and it gives you a lot of insights into the type of NDQI data they're collecting. Finally, we always want to remember that psychiatric aides or psychiatric technicians have the highest rate of non-fatal injury and 5 times higher the rate of any other nursing assistants at other hospital sites. So it's a significant problem. It's increasing in hospitals. It's increasing in our communities. Now, all of us here today are really involved in these healthcare settings. And if you're an administrator, a therapist, a manager, a medical director, or frontline staff, we know from our work that a staff injury impacts the entire team. And as the news of the injury spreads, it starts impacting the whole hospital milieu. So all of us are being affected by workplace violence, and we all now have to be part of seeking the solutions. If you look up workplace violence, I did on Google, you see they actually now have categories under best practices, and they'll put you through all the what are the best practices. You can also look to many organizations that have their guidelines for model programs. I've just actually put 3 of them here just to demonstrate the key components of these guidelines. So you can see right under the names is the name of their guideline. And you can see that the similarities among these 3 organizations of, it's important to form a team, to have management commitment, to have employee participation. Staff training is in every guideline. Worksite analysis, identifying hazards, another part of most guidelines. And finally, looking at how we're reporting, and in some, post-incident reporting and what we need to do about that. So you would think there is a really lot of rich literature out there, and there is. But actually, when we get into the evidence base for workplace violence approaches, probably staff training has the most literature, but a segment that is particularly involved right now in looking at evidence is emergency departments, and rightly so. And here's a recent review of what these authors, they looked at 21 individual studies and 3 reviews. And although every report will say that there was some gains at their site from whatever strategy they used, they find there's really insufficient evidence across sites on what exactly what it has the strongest evidence to support the effectiveness of any given strategy, particularly in the ED. So we're in a kind of funny time. We're in lots of recommendations, and yet as we're starting to look at the evidence, undergirding them, it's not as sound as one might think, or not as extensive as one might think. Now, I think addressing workplace violence has to occur on several levels. And so we need, of course, there's 2 bills right now going through Congress on protection of healthcare workers. And so we need policy, legislation at the state level. There's a recent report in JAMA that almost every state has enacted some sort of workplace violence regulation. They differ, some on whistleblower protection, some on enforcing more enforcement against perpetrators. We know that reporting is an issue. Estimates are about 1/3 of what occurs in workplace violence gets actually reported. And we know that the data systems on a national level are also, they're not going to provide us, except for OSHA, which is injury related, they're not really going to provide us with what's going on in the field. Press Ganey, which has some of the best data, is actually only 40% of hospitals are members of Press Ganey, and you have to be a member to see Press Ganey data for the most part. So all of these issues that require action, my colleagues and I wrote an editorial about them, and you can Google it. We're fortunate to have it published in Health Affairs. And so I understand the broad reach of what we need to do. Today, when I talked to Jane and Dr. Khan about what they'd like me to talk about, I decided to focus on the local level. And again, we're seeing site-specific strategies in the emergency department. We have a recent data on training from the UK. It's up there by Owen Price et al. It's really extensive on their research. We also have out there guiding principles from professional organizations. I just put a picture of one up. But today, I'm going to focus on short-term inpatient units. And I'm going to ask you to take this as a challenge, an opportunity to readjust our sights on what can we do to keep units safe. So because of that, I'd like to look at some fundamental beliefs that are growing up rapidly around inpatient aggression. And a belief is our attitude that a proposition in a certain situation, it is the case, it is true. And I propose that there's some pitfalls in following some of these traditional beliefs about the causes and the solutions to aggression. So I'm going to go through 3 of them, and I'm going to ask you to consider alternative ways and alternative activities we might pursue. I think that these strategies are within your grasp in the audience as leaders, as managers, as the therapists on the team, and of course, as the inpatient direct care staff. So the first belief that is very strong right now is that mitigating inpatient violence depends on rigorous violent assessment screening, and I underscore the word rigorous. Violence assessment tools, of course, have their place, and I don't want anyone to walk away and say, oh, Kathy Delaney said we should do violence assessment tools. No, they have their place. And I just put up this CDC as a visual to show you some of the categories, which I think are useful to think about. There's probably about 20 in the literature of violence assessment tools. But you can think about them as like a triage tool where you're looking at violence history, and at the beginning of a person's admission, you might want to do an initial assessment of that. We also have indicators for violent behavior, like the DASA and the BRACET. And then we have a danger assessment tool, which is more about estimating a person's history of assault or homicidal actions. So each of these have a role to play, but repeated daily on each shift, I think they embed a belief that violent incidents are best understood and examined in terms of patient characteristics. And I think there's a couple of dangers with that. first, when we gather that data and we chart it, I think it influences how we come to view individuals. This is an article I recently read by a man named Devereaux, and he examined what goes on in the thinking of nurses based on Daniel Kahneman's think fast, think slow theory. And one of the aspects of that theory is that the information we gather primes our brain as we think fast. And so if we have so much risk assessment data, I think that it might prime our brain. I took Devereaux presents a hypothetical patient, and I've adapted it. It's a little different than what's in his article, but same principle. Let's look at Mary Jones. And the top line is how we might come to think of Mary Jones, that her diagnosis, that she's agitated around discharge, she's threatened to call the CEO of not discharge, she's been restrained. This kind of data, good to know, but we don't want to dominate the image or the narrative that Mary also has 3 school-age children. She worked as a teacher. She's tried several avenues to stabilize moods, what she likes to talk to staff about. And we'll discuss with you what helps her calm. So we don't want to get so primed on the first set of data that we start forgetting the basic principles of what we want to achieve, which is to understand the patient's narrative, how they got to this point, and what they believe will help. In addition, a focus on violence risk in line with patient characteristics, it diverts our view from other elements perhaps involved in inpatient aggression. Here's a very current article on risk factors from a review of the literature. And Limonal had 2 categories of risk factors. One was attitudes and behaviors when patients and families are under intense emotional charge and expectation. That's a risk factor. But the other risk factors, she states, are shortage of staff, lack of training, and then systems factors like overcrowding, long waiting hours, inflexible visiting hours, as well as differences in language and culture. So we see that our risk factors are really much broader than patient characteristics. And I added one for inpatient. We know that we call it unit churn. It's not used a lot in the literature, but it's when on an inpatient unit, you get 3 admissions in an evening shift. Those rapid admissions start to increase unit acuity and by this phenomena of unit churn. So how might we spend our energy instead? What can we do instead? Again, not taking away all risk assessment, but focusing our energy. I often joke with my students that I have one slide that violates every rule of PowerPoints of having no more than 30 words on your slide. So here it is early on. But I wanted to let you see the Joint Commission standards, which are actually 2 years old now. But these new standards are around violence reporting, tracking, and analysis. And I think they're very, very important. And you can see that it talks about a standard of how a hospital manages safety and their work analysis related to their violence prevention program, how it collects information in the environment, and also on staff training. And we can see here too that there's a standard of what the leaders are doing to create and maintain a culture of safety and quality, which is around how they've instituted policy and how they've responded and processes they have to support the victims. Now, when you look at the Joint Commission standards, you'll see that it involves collecting data, developing a process so we see patterns of violence institutes. It will also depend on developing a structure of reporting, and it will also expect a data analysis that will inform QI efforts. So, excuse me, I have to move my slides over. So what I'm reporting is that suggesting that there should be a paradigm of incident reporting, that we need to shift it a bit if we're really going to accomplish a team analysis. We need some perhaps new reporting of procedures, ones that will entail examination of service factors. The managers and administrators in the room today, it really will be your responsibility to form these teams. And of course, start looking at quality improvement data, like should you control admissions during high milieu activity? Would that be a strategy? I think we need to devise new procedures for incident reporting. Right now, it's very much relying on frontline staff. And I think we need to look at data gathering using procedures that fit better with workflow. After an exhausting shift, I don't know many frontline staff that want to sit down and do a 3-page report. But there's other methods. I know Joanna Inako was here last year. I'm privileged to call her a friend. And when we talked about her study, which she talked about later, is when staff carried clickers to click their exposure to all sorts of aggression. She believes that is not something you should do all the time, but perhaps once a quarter, you might want to get a general sense of the amount of aggression of all sites on your unit. There's also something called the Patient and Staff Conflict Checklist. It's out of the UK. It's got some reliability and validity to it. And in this, the charge nurse takes this checklist of about 20 behaviors, including aggression, suicide, alcohol use, absconding, it's from the UK, and 8 uses of containment. And it is the charge nurse that tallies these different incidents. And again, as I've already emphasized, we really need to start thinking of incident from a health service perspective. And what are some of the antecedents, and even like your staff engagement scores, lots of different data that you might have, and how can we look at them and start moving towards reduction or harm minimization. Oh, plus, if you do all this, you'll meet Joint Commission standards. So that's another added plus. Second belief that I'd like to talk a bit about is that safety depends on increased surveillance, guards, panic buttons, video monitoring. We're actually seeing that the data is really weak on the effectiveness of these surveillance methods. This is just a recent article, a very rigorous study, again, I'm pretty sure out of the UK, where they went 26 weeks and measured all sorts of inpatient aggression and violence, instituted various risk assessment monitoring of various tools, and 26 weeks after they measured and found there was no reduction in aggressive incidents. There was actually an increase in seclusion use. The second one is an article that is still in preprint, but this looked at 27 studies involved with monitoring, body-worn cameras, wearable sensors, and they looked at the impact on self-harm, violence, aggression, and they concluded that there was insufficient evidence to suggest that any of these surveillance techniques are effective in inpatient settings. So as we move on this belief in surveillance, the other issue about surveillance is that it reinforces a risk management. Risk management embraces identifying risk, assessing, controlling, and reviewing risk. Of course, we need to know what hazards are in the environment. And we should be mindful of controlling them. But we don't want to get to a reliance on surveillance, because so strong it can also create a risk-averse environment. Of course, our awareness of risk factors is important. Our awareness of ligatures was very, very important. But also less studied was the impact on patient dignity and privacy during this era. We know that at some points in the last 5 years, strategies, rules, and policies around risk management really began to take precedence on our unit. We also have not paid as much attention to, as we rid the environment of any element that carried any risk of harm, how that impacted the environment of care. As we gave patients only rubber short pencils to write with, what does that do to their ability to journal, to write, to just have some of the normalness of life? So I think we need to understand the impact of a risk-averse environment. I put 3 points up here from 3 different authors. One is an article by Solomon that's highly quoted, and she believed that risk management actually gave rise and legitimatized practices that were ineffective, sometimes unethical, that eclipsed meaningful treatment. Authors Felton and all said that when risk dominates how patients are seen and understood, they become objectified and are seen as objects of risk. Finally, a recent article in the AMA Journal of Ethics, Dr. Edward Morris talked about how adverse event frequency combined with threats of punitive actions, regulatory sanctions, place such pressure on inpatient staff to prioritize managing risk of dangerousness over other therapeutic needs. So we want to understand some of the subtle ways that a risk-averse environment may have impacted inpatient care in the past. Just one other additional application was the time it takes when you have on nursing time. So when surveillance moves into continuous screening, risk management, close observation, you can take precedent over this in nursing engagement. I just put up 2 time and motion studies of nurses on inpatient units. One is rather older, but in this one, they actually measured and looked at how much nurses engage with patients teaching symptom management. Very small. In a more recent one, they found that nurses spend only 32% of their time in direct care and much more time in indirect care charting and service related. So we need to protect frontline staff time. So how might we focus our energy? And I'd like to propose that we adopt an engagement-focused approach to creating safety. I'll let you read just a definition of patient engagement. Here's one study that used an engagement type strategy to manage risk. When they perceived a person was a risk, they had a whole protocol of increasing engagement with that person. And they report good results. This is similar to the work done at Northwestern with Stephen Ray, where he proposed an engagement strategy to help people who are having suicidal thinking. So in an engagement strategy, I think that as we look to increasing patient engagement, it's really intentional. And I just want to make a pitch that I think engagement is a fluid process and it operates on 3 levels. I think there really should be engaging at the point, of course, of minor anxiety, distress, escalation. I recently went to a nursing conference where I saw a team from an inpatient unit in Alabama present. And in their project, the staff were educated with a rounding tool that contained identification of early warning. There was about 15 early warning signs. And then on the next column was things you could do to engage. In a quarter, they had a 46% decrease in assaults. So I think when we're looking at the DASA or the BRASET or those behaviors that pretend aggression, really at this point, they're probably in most staff's head. They should be in most staff's head. Irritability, refusal to follow directions, persistent. And we really need to teach staff to engage at that point in all different types of ways. I think that as we try to increase engagement, I like the idea that we need to convey to newer staff, especially, the ordinariness of interventions. Patients can view that as therapeutic, and they have. So humor, banter, even help with daily activities. I love the term ordinariness of interventions. I recall when I was helping manage a child unit, and a prospective candidate for medical director came and looked down the hallway, and staff were sitting in chairs among the kids and laughing. I think they're watching TV or something. And he said to me, Kathy, when I'm unit chief, I'm going to make sure staff have time to really do their work. And I said, well, they are doing their work. This is their work. Sitting, being present with these kids, laughing, of course, also observing them, but this is their work. And I think the ordinariness of interventions, we can get escape from that. But just so we're clear, I think we also need to teach newer staff that in this flow of intervention, we're also engaging with intent. So I always think of it in three buckets: cognitive, behavioral, affective. I once wrote an article about it called "The Top 10 Interventions of Inpatient Nursing," and discussed how, when you're changing appraisal of a situation, you're really working on a cognitive, you're simmering down affects, affective, but when you're changing reinforcement patterns, it's behavioral. For instance, on a child unit, again, if you have a child that is often can't sit during meals, but you happen to catch them sitting, even if halfway off a chair, you say good sitting, and that's a shaping. So you're a shaping intervention, you're reinforcing a behavior that's an approximation of the behavior you want to see. And we would talk about this a lot, these ways we want to always be integrating these type of principles when we're intervening. So that's a lot, I know, but I think that inpatient engagement is, it's not understood fully, and I think it's terribly important to the safety of a unit. If anybody out there is listening and wants to start thinking about increasing engagement, I'd just like to bring up that there's a questionnaire now. It's about 2 years old. I've seen the first article of a unit that used it with good results, and you can really measure and validate how your efforts at increasing engagement are going. Finally, I'd like to talk about the belief that adverse events on psychiatric units are preventable. I think probably most of the audience has been involved in an incident, and you might think back, I did this morning, was it preventable? What ones are preventable and what ones aren't? But a belief has grown up that almost all events are preventable. And when that belief takes precedent, best practices rely on rules and standardization. And event and cause become a linear connection. So when that happens, safety strategies in a range of areas, they start being aimed at reducing reducing variability and increasing standardization. Adverse events are looked at as like a product of error or failure to comply with accepted practice, and thus they're preventable. If we really view this adverse events in that way, and I'm talking about all adverse events, or some adverse events preventable, of course, but not every adverse event can be looked at in a cause and effect linear model, where compliance depends on compliance with standardization. Here's an article, and this is a lot of the thinking of an Australian author, Jacob Sevenson. And he looked at 93 articles, and they were all looked at strategies used to prevent harm and to deal with adverse events. And he took the 93 articles and he grouped them into 7 categories. And I've only done a facsimile of one category, which was the 23 articles he found on risk management. But in categories, he found most of the articles dealt with suicide, risk of harm reduction, risk of violence, and fall prevention. And you can see that here. These are the number of articles. This is the strategy that was used, and this is what the article aimed at. When he looks at all these, he comes up with a couple of conclusions. One, that psychiatric units are really unpredictable environments with a good deal of performance variability. That safety is really an emergent property of interactions and the systems and who's on the unit and what's going on in a lot of the elements. That his conclusion is that it's really the individual adjustments and skill of staff to engage in dialogue could be the most important safety strategy you have. So his bottom line is that fundamental to patient safety are well-trained and well-trained staff and staff who can adapt their activities in response to increased risk. I debated about this slide. It's a funny slide. So I'm just to end here, I'm going to talk about what I learned about this staff skill set that's critical to safety, this ability to deal with unpredictable situations. And my colleague and I, Mary Johnson, were fortunate enough some years ago to get federal funding for a grant. And we wanted to look at units that had very acute patients and yet used very little restraint, because at that point, the real focus was on coercive measures. But part of that was participant observation. And so at that point, they still allowed benches in hallways. And so I would, 4 hours a day, 3 days a week, I would go to these units. And a lot of times I sat on a bench in the hallway. I would go at different times of day, different days. I'd go at shift change, I'd go at mealtime. And after about an hour in the milieu, I would then go into a small room and write notes, field notes of what I observed. And this unit had 30 patients. And on the long hallway, they often walked in a circle. And I saw quite a bit of aggression between patients. After we looked at all our notes and coded them and our interviews with nurses, we isolated nursing behaviors which we considered essential to keeping the unit safe. We divided it into novice practice, where the newer nurse is really just becoming aware of their behavior, aware of the milieu, being there. Then we looked at the expert nurses and the expert technicians on this unit. The psych technicians were so integral because there was many that were true experts, and how they more dealt with balancing the needs of the patient with the needs of the milieu, how a lot of their activity was caring and connecting and deciding how to respond. To illustrate that, I wanted to give an example from my field notes. This was a staff member's ability, I think, to adjust to unpredictable. This was a nurse that explained to me how she decided to deal with a patient who had just spit on another patient. I witnessed it after the fact. I talked to the nurse and asked her to explain what she was thinking. And here are my field notes. And I am going to give you a break from my voice and let you read this. So I think this is a really exquisite example of the multiple levels that this expert clinician was thinking about. And it was happening instantaneously, but as she was deciding how she would respond. There's also this recent article, you don't have to sit on a bench find plants. There's a recent article that interviewed skilled nurses, and they came up with some of the approaches they do and how they think when they're preventing patient violence. And I think on this list, I could, and those of you who are expert psych technicians and expert nurses that might be listening, you can see how this part of your everyday job, especially building trust and rapport, what's behind the behavior, trying to meet needs, remaining flexible. So how can we develop the intuitive expertise of staff? I think within the environment for our newer staff, we really need to have opportunities for them to practice interventions, interactions, feedback about their approach. I think cultivating staff situational awareness is so important. We used to have this, I've worked 40 years in inpatient treatment, and we used to have this thought that we never knew where new staff were because they hadn't developed the habit of when they were walking into a patient's room, telling people they passed where they were going. Seasoned staff usually know where each other are on the unit at all times. So developing and cultivating situational awareness is just something that becomes an ingrained behavior after a while. But I think for safety, we need to be more mindful of it. Along with that, I think we need opportunities to dialogue with the entire team about patients. What's effective? We used to have a Wednesday meeting, it was called, in the morning when our younger patients were in OT on the unit and our older patients were behind closed doors, and we used to go into the quietest area and still be on the unit. And for about 25 minutes, we would talk about patients and who was our biggest challenge and who had relationship leverage with that patient and what we were going to do that day. I think dialogues like that encourage staff to externalize their work and also the philosophy of care and also about their interactions with patients. It's a chance to explore with the entire team what's in the environment that makes things go well and how can we optimize them. It's my last slide on this. And I just want to talk a minute about this skill development. It really does demand an environment that facilitates staff engagement. This is the first two blocks are an older study by Christensen, where in order to improve the safety culture of the unit, leadership actually met and discussed what they were going to do to support dialogue on the unit, to support teamwork, to support the recognition of stress among staff. And before and after this intervention, where leadership kind of shifted their perspective a bit, they gave staff a safety attitudes questionnaire, and it has 6 dimensions, and you can see them in that box of how well does the team work together, how safe do you perceive it, what's your job satisfaction, how do you perceive working conditions. And they found that staff's rating on these characters statistically improved after this leadership intervention, where leadership shifted how they were working with staff. So when we think of all that I talked about, we also need to remember the work environment where staff experience teamwork, safety, job satisfaction, that the research, I think, then has to move to how does that improve patient staff engagement. I could only find really one article that talked about this. And then if we really get sophisticated, it would be wonderful to tie it into the patient experience and also to their perception of safety and the patient's perception of healing that went on in the environment. So, in summary, 3 beliefs I've asked you to explore. 1, is it useful to examine violent incidents exclusively in terms of patient characteristics? Does safety depend on surveillance? Are adverse events always preventable? I suggested that we take a broader view of how to deal with aggression and lean towards strategies aimed at keeping units safe, even changing our language to this idea of let's protect the safety of patients and staff. So violence assessment tools absolutely have their place. Those key behaviors, they should be in people's heads. The key behaviors that pretend violence or agitation should be in people's heads. But let's also think about using Joint Commission standards to map service-related variables that may be associated with aggression. Expending efforts at building surveillance system, cameras, alarms. Let's also encourage staff to focus on engagement and building relationship leverage to bolster both interventions as well as support patient recovery. And standardization restrictions to prevent adverse events. Let's focus on developing the intuitive expertise of staff and their capabilities to deal with changing milieu situations, the unpredictable. And let's really focus also on leadership efforts to build a supportive milieu for these staff interventions, which require imagination, sometimes taking risks when you offer patient choices, and staff need to be empowered to have that kind of freedom with those interventions. I'd like to end with a quote by someone you all know. And once again, I'll let you read it. Thank you. I was a bit nervous about this presentation. It's a little bit different than what you might have expected to hear. But then when I read about your site and read this quote by Dr. Gerber, I realized that at the heart of your institution is the patient narrative. And at the heart of your institution is understanding and engaging with patients. I'd like to thank everyone for being here and having me here. I'd like to acknowledge Nursing Week, which I'm sure has been acknowledged. And I'd also like to say thank you, which is on my last slide, which it doesn't matter, to psychiatric technicians. Psychiatric Technician Week is actually in August, I found out. But I've worked alongside psychiatric technicians my whole career and understand that they're so essential to safety and often get left out of the conversation. So thank you. And I'll take questions. On my slides are all my references. And I hope they follow APA format. I checked them twice. So thank you very much.
Dr. Delaney, thank you so much for such a passionate and thoughtful, empathic lecture. It's so inspiring for me to hear and brings me back to working in a psychiatric emergency room and so many interactions that I'm remembering. So we'll now get started on the question and answer part of this grand rounds. So for those of you in the Martin Center who are attending together here at Silver Hill, as I mentioned, if anyone of you has a question, please input that through the Q&A function that Peggy, who I believe is running technology, might be able to do there. And while everyone begins inputting questions, it really is my great pleasure to introduce Dr. Immaculate Khan, who is our Chief of Nursing here at Silver Hill Hospital. And Immaculate, thank you so much for joining today. And I'm wondering if you can start us off with some words or a question.
Absolutely. Thank you so much, Dr. Katzman. Dr. Delaney, I cannot thank you enough for being here with us today. Right now, workplace violence is such a relevant issue in nursing. I would like to start by saying Happy Nurses Week to all my fellow nurses. It is really, truly a pleasure to work alongside each one of you, and the work that we're doing is tremendous and valued. Today, as we talk about workplace violence, I cannot help but remember one of our own who died on October 28th of 2023. Her name was Joyce Grayson. She was a home care nurse, and she was strangled to death, suffered multiple blunt injuries, and she was found dead when she went to provide care to a client at a halfway house. So today we remember Joyce and her courage, and also while we address this issue of workplace violence. I like what you said, Dr. Delaney, that we all have a responsibility in seeking solutions and addressing this issue. And I'm really happy to see that our legislation has taken this issue very seriously. It is a significant issue in the legislation right now. And the Connecticut Nurses Association has really done a great job organizing our nurses here in Connecticut, and so is other organizations as well. But my question to you, Dr. Delaney, is as we are working to getting our nurses to be more civically engaged in communicating with our legislators, what suggestions do you have for our nurses, or what that conversations they should be having with their legislators around this issue? Thank you.
Thank you very much, Dr. Khan. Well, I think there's a couple of levels you can get involved with policy. I recently went to the Illinois Policy Day, and you have an opportunity there to stand up at one point and say what your policy, what your focus is that day. And I think that alone is terribly important, because I think we need to keep this conversation going. Those of us, and I bet you, Dr. Khan, you and I remember 10 years ago with restraint reduction and the Hartford Current. Actually, it wasn't 10 years ago, it was 1999. And that conversation about restraint reduction kept going for really 10 years. And it generated reform. And I think it was really kept going by consumer groups and by nursing and by medicine. Everyone was involved. But I get worried that the focus on workplace violence might be sporadic, that every incident might attract attention, but then our efforts might fade away. So, wait a minute. If my husband was here, he'd be like, get off the soapbox. But I also get worried that we don't have good data systems, that and we're, at restraint and seclusion, we have federal reporting of numbers, and we're not going to have that. So I think that getting involved in policy, getting involved in talking to legislators, and keeping the concern for patient safety and staff safety is terribly important. Even you might decide, this is a tangent, but you might decide the ask might be the closure of inpatient beds in your state. It might be something as much as our units overcrowded, are people staying on our child and adolescent units, so little was paid to how many kids stayed too long during COVID because there was no other place to go for them. And so there's a lot of policies that might be impacting our environments of care, EDs and outpatient. So I think we need to keep the conversations going. So it's important to, if you have a policy day and you can go. Now, what should be the ask? Oh, the ask is so important. For any of you involved, is when you start working in policy, you learn two things. Everything has to be on one page. It should be sufficiently different, so it shouldn't be just a can, and the end should have an ask. So what is your ask? I think that for me, I have two asks when I talk to people. One is to Joint Commission. And I ask Joint Commission to really take their standards seriously, to really have hospitals expect that they're going to be asked about all their data and to take seriously those standards. That's my ask to Joint Commission. And then I think our ask right now our ask right now on the federal level, this sounds a little confusing, and then you can cut me off. Dr. Katzman can, Jane can cut my screen. But I think that when you as a consumer go on like OSHA and try to look at injury data and try to look at data, it's really hard for me. And and I think that OSHA needs to make the data, it's our best source of data. And I think it needs to become transparent so that we can all use the site with ease. I looked at the current injury rate for psych technicians, and I spent about an hour on the site. And I just was like, how, we need more, we need better data. And at least the data we have, it ought to be, that government agency should be able to put out a news brief to us every year about what are the important parts of the data. I guess that would be my ask. Ooh, what would your ask be, Dr. Khan?
Thank you so much. You really put it all in perspective as it relates to the ask. I see there's, as a CNO, you're always thinking of budget, right? And so speaking to legislation, there's interventions that we could implement within our workplace. So my ask will always be provide the resources so that we can keep our staff safe at the hospitals and at the facilities, that they work, because safety is number one. And in terms of budgetary item on the line item, let's include some of that to help hospitals.
Right. And that all of a sudden, Dr. Katzman is becoming, we could talk forever, Dr. Khan and I, so you should break in. But I'll just say one thing about that. I don't worry about Silver Hill or Institute for Living. I worry about little Saint so-and-so hospital in the middle of nowhere that might be a corporate hospital. And you worry when you say we need whistleblower protection. We need to make sure that those staff in those hospitals also have a voice. And we need data on the differences. There's one person, Morgan Shields, who publishes quite a bit about institutional hospitals under private ownership. And I think we need more data about that, because those are the hospitals that I worry about too, and resources.
Excellent point.
Yeah.
Thank you.
You're sure. Maybe I spoke out of turn about your hospital, but I would assume.
Not at all. Dr. Delaney, I have a question for you, and then we'll get to the questions in the that are coming into the Q&A, and actually many compliments and gratitude.
Oh, thank you.
Yes, we'll read those out loud too. And as I mentioned, you made me think of kind of years that I spent in the psychiatric emergency room at the University of New Mexico, which is a safety net hospital, and
Mhm.
really fairly acute environment, very acute environment. And I would work all day, and then I was there overnight, and then would work all the next day, and was so amazed by the nurses, and as you said, the psych techs that were there. We just created the greatest team. But at times myself or others could get into something with a patient and be more provoking. And I'm wondering kind of your ideas about in real time, how to talk about that on a team and how to give feedback to somebody who you think might be escalating a situation, or how do you get your head around communicating between team members to de-escalate something that might be happening?
Well, that's a hard one. That's a really hard one. And and I'm sure Dr. Cantu as a manager, when you start seeing a certain staff that's always the first person in, the first person to jump into every escalating situation, it's your job to talk to them, and you have to, it's your job as a manager. As a fellow staff person, it's harder, but you certainly have staff, and because they're anxious themselves, and I don't think there's anything malicious, but it's really the manager's role to step in and talk to those people that might not be suited, and yet they're the first people that do it. They're the first people in.
Yeah.
Yeah. EDs right now are they're so struggling with this right now. It could be a whole separate, their situation is so different. I it's very different. It's a very, if you think about it, and then we'll get to questions. But if you think about it, in a psychiatric unit, let's just look at like the 8 behaviors in a dynamic analysis, a DASA, irritability, as psych nurses, if they saw that, the first thing they would do is step back, intervene, and gauge how well is my intervening working right here. And it might be to decrease stimulation. It might be a lot of different things. But ED nurses, when they see that, they can't step back all the time. ED staff, if you've got to take vital signs, I don't know, like there's no other profession that when they gauge a risk of aggression, I don't think still has to keep a physical proximity. Have you thought of? I thought about that. It's going to be a conundrum about when we see more risk assessments in the ED, which we're seeing so many articles on doing them, what they're going to do about it. Are they not going to? What are they going to do when they decide someone's irritable or demanding or not listening to directions? I don't know. It's a hard problem. Sorry for that tangent.
No,
but I've been thinking a lot.
You.
I've been thinking a lot about emergency rooms and the conundrum of physical proximity and risk is very different there.
So Dr. Khan and I will alternate asking you questions off the chat here, and I'll start. David Mathis is asking, how would you respond to a request from staff to medicate? That's the question. Yeah.
Well, let me just say that I think there's a really there's this thread of interest in nursing, and I'm sure in medicine, on chemical restraint. And what is chemical restraint? And talk about an industry that comes and goes. That really comes and goes. So I personally think that when you're working in a unit with acute people, you need to know what's in your back pocket. You have to know exactly what resources you have. And is medication one of them? Absolutely. Should it be used, excessively? No. But you know, you can always look at whether a medication was used excessively or not. But I'd like to ask who asked the question what they think. I think in order for you to stay calm when you're facing an unpredictable situation, you have to know your resources, how many staff, the experience level of staff, everything. And medication is, what do you think, Dr. Khan? Medications is one of those things in your back pocket.
Absolutely. And also, when to give the medications is very important. Um, I think our focus here at Silver Hill has always been prevention and getting to know our clients in such a way that we prevent. We have that connection, that bond that we can be able to pick up what's going on and how to appropriately intervene. So in terms of medication, we try to really try other strategies before medicating. But that really is because of the connection that we really get to know our clients here at Silver Hill. And if it gets to the point where we need to medicate, we medicate. But that is really not the first line of intervention.
David Mathis just typed in just a response, actually. I think,
Oh,
Dr. Delaney, because you asked him, and his tells us that medication should be used only if it is in the best interest of the patient. And benzos might be the safest, he writes. So anyway, there's the response from the person you
oh,
asked.
thank you. Absolutely the best interest. And sometimes when you're right there in the situation, you're really weighing a little list in your head of what is the most coercive measure. And maybe you believe that a sublingual Geodon is a little less coercive than a possible takedown. So it's your judgment. And absolutely, we should, just the same way we review every restraint incident, maybe we should start reviewing more our PRN and our debriefing around how they were used.
Absolutely. And that's a key, that's key in terms of the debriefing. And that's really how we really have a plan in place on how to provide that effective care, compassionate care that we strive to provide for our clients here at Silver Hill. So we'll move on with some of the questions because there are some great questions here. And so this came from an anonymous attendee, and this person said, "This is an amazing discussion. You are putting into words concepts I have struggled with in the psych ED for years. Where does nonviolent crisis intervention come into play?"
Well, I think that we're gonna, probably there's 5 more companies formed to teach nonviolent, CPI and all the different schools. When I read the recent report I put up there by Owen Price out of the UK, it was so much more extensive. It was the UK, remember, so it was a 2-day training, and where the staff went. That was a lot. That's a long time. But I think we're going to get more sophisticated about engagement and different forms of engagement depending on what you're moving along with the individual and what you think they need at that point. So of course it has a role, but this idea of talking down and lowering your voice or something, I think it's much more sophisticated than that, personally.
So I'm kind of overwhelmed by how many people are typing in how outstanding and amazing presentation was and how it's the best ever. So hopefully we can get to read all this.
There's nothing like packing the audience with nurses.
There you go. Well, Irene Candy Bouch says, very good presentation. All of our staff should see it. And Dr. Stephanie Palmeno, I think in response to an earlier conversation, I'm putting there that the Connecticut Nurses Association has added a new annual award in recognition and memory of Joyce Grayson, Stephanie Palmetto, past
Very
president of
nice.
CNA. So let me get to even a longer thank you from Danielle Morgan, who says, Dr. Delaney, thank you so much for all your research over the years. I'm finishing up my dissertation and have admired and cited your work throughout. I am a bit of a groupie. As a 25-year psych APRN, I turn my focus on provider health, and I'm so excited to see you focus on therapeutic relationships and the power of the clinician-patient interaction. I have found this in my data, and this drives my research agenda. Thank you for your passion. We need to address workplace violence and provider health, mental health throughout this lens. So there's a fan. I don't know if you have
Well, thank you very
response
much,
to that.
Daniel.
Yes.
And good luck with your dissertation.
So here's the next question. Are you seeing the degree of staff turnover in psychiatric settings that is being seen in general hospital settings? And if so, how is that impacting the culture of caring, compassion, and patient-centeredness that you are working to instill?
Oh, that's such an interesting question. You know, I have my personality as an academic. I never answer a question if I don't have data in my head. So I'm going through my data on nurse turnover, and I just don't, except for large nursing surveys, and they often omit psychiatry. I really don't know if we have any data on the turnover in psychiatry, except probably anecdotal, especially at the last year and a half of COVID, where we heard all sorts of testimony about turnover. I recently saw a HRSA workforce navigator that said we have 80,000 RNs that identify themselves as psychiatric nurses, and 60,000 work in inpatient units. So that is a big cohort of people. And that doesn't even include psych techs, which whenever you talk about turnover, you really want to think about your psych tech turnover too. So I wish I could, maybe Dr. Khan can speak, but again, she'll probably be an N of one. If whoever asks that question, if you're doing a research study and you find a good article, email me, because I think it's a good question, and I'd like to have an answer for it next time someone asks me. Just let me say that all the literature tends to be on this measurement of burnout, and I believe in burnout, but I like a single unit's burnout rates. I don't know. I just can't do anything with that. Thanks.
Dr. Katzman, did you want me to ask the next?
Yeah.
So this is from also for an anonymous attendee, and this person indicated, it can be difficult to view things in a new light. It reminds me of a newspaper piece I just read last evening. Opinion in medicine, the morally unthinkable too easily comes to seem normal. The New York Times, NewYorkTimes.com, do you have suggestions for how to present this new approach to leadership? I worry that it wouldn't be acknowledged appropriately. We had an episode of WPV, and we're told it would have happened even if staffing was good.
Well, I'm hoping that the Joint Commission standards are leverage, because what you'd want to see is a pattern. I mean, any one incident. And so if your unit can really devise ways to collect incidents of aggression or threat, and then you can see a pattern of when it is, what time of day it is, what other situation was going on, then you'll have something. So I encourage you to, you can look on the Joint Commission website if they're in the Journal of Patient Safety, but if you don't have that, and and you should have them. Every nurse on this call that should have those standards and should ask, where are we with them? And you should have a nurse on the committee, and a psych tech on the committee, and look at patterns of aggression and violence. I think when I talk to, again, I'm bringing up Joanna Iannacco, but I know that you know her in Connecticut, and we often talk. The other thing you'll have to decide as a hospital is, what are you going to measure? Are you going to measure every time a patient swears at you? I don't think so. So like Joanne was saying, like maybe when the threat was to the level that you got scared inside. Do you know what I mean? Maybe that, but you're also going to have to decide what you're going to measure, because there's no universal standard of what anyone's going to measure. And it won't be assault with injury, property damage, but I don't know if people are going to measure threat. I'm sorry for that explanation. It's something I've been thinking about.
Yeah. Excellent.
I'm gonna drop down a few to get to a question from Peggy Sawyer, who asks, is there any data on seclusion versus restraint related to staff injury?
Oh, Peggy, I feel like I probably know you, Peggy. I just read something about, I didn't read the article, but I just read it. I just saw in an article about the rate of seclusion, the rate of restraint for patients who cause staff injury, or they've been the perpetrator of staff assault with injury. Does that make sense? The rate of restraint of patients who have been the perpetrator of staff assault with injury. What do you think that rate of restraint is going to be? So, I mean, I think that is, that's the last article. Boy, it's killing me that I didn't read it, but that's one of the things I've read recently. But I wish, if again, same with the last person, I'd love to know what you think about that. We're better at recording our rate of restraint, which is going up, by the way, nationally again. So you should be able to look at it on your unit, and you should be able to compare it quarterly with national data. Interesting.
There's also something from Deborah Ostreicher. I believe you might know Deborah. She said, I'm thrilled to hear you speak. Great fan of your earlier work about growing psychiatric nurses, and very happy to see you integrate this into violence risk and mitigation. Thank you for this presentation.
Thank you.
Yes.
Thank you very much.
And Deborah also works with us at Silver Hill, and amazing.
Thank you.
So I'll let you take the lead,
Sure.
Dr. Katzman. And
Sure. I want to put together two, a comment and a question. I'm going to mispronounce Candace's last name, Maffei, I think, maybe, and I'm sorry if I'm saying that incorrectly. But wow, if I could ever get a comment like this. This has been one of the best presentations that I have ever attended. So there you go. My mind is full of ideas of the work that needs to be done in my department. You have validated a belief that I have held for a long time, that it's not all about restraints, takedowns, video monitors, and Brossett scores. It is truly about engagement and trauma-informed care. I have my work cut out for me. Thank you so much, and happy Nurses Week. And then a question. What RN applicant characteristics would you look for in an employment interview that would be vital to hiring the type of staff necessary to accomplish this new intervention of staff engagement, rather than just meds, restraints, and takedowns? What interview questions would you ask? Thank you.
Wow, what a good question.
Yes.
Can I just say to the first person, and I know that I've talked about this, but that new de-escalation, it's got a long name. I looked at the protocol of it from the UK, and the first half of the day is on trauma-informed care. and what responses look like in trauma. So it's really a broad overview of what we really need to learn about aggression. And I was glad to see. And then the last one is on using sensory issues, which is another thing that I think is neglected. What would you look for in a staff member? Well, you know, what we would hope to engender on units where I worked is we would hope to engender that people would take risks sometimes, try novel things, and I don't know. My husband hired a lot of people, and he always used to ask him, "What's the first job you went for the day after you first graduated?" To know people's level of imagination and curiosity. So that's what I remember he asked. But psychiatric nursing services are good at settling down and really trying to get to know someone, and that's what you hope for. I have to say that also on the unit where I worked for many, many years, there was a nurse, a good nurse, fine nurse and everything. And she told me that she was scared, and she was always scared. And if she could, she didn't want to be in takedowns and volatile situations. And I said, well, on a kids unit, especially, someone always has to be circling the unit to see how everyone's doing during a volatile situation. So that should be you. So you have to accept the strengths of people too, I think.
Heather O'Brien said,
Hi,
"Thank you,
Heather.
Kathy." She says, "Thank you, Kathy. In regards to ordinaries, you are right on. I always use this quote from Maya Angelou when teaching nurses and techs about engagement. Only equal engagement in small talk. Your comments and observations are timeless. Thanks again. Loved this talk."
Oh, I think that's Heather O'Brien from Rochester. Maybe there's probably more than one, but thank you. Thank you.
Absolutely.
Alessandra Robertson has a question here and asks, Dr. Delane, do you have any suggestions or places to look at systems folks have developed to collect the data about aggression and violence occurring on inpatient? I agree that I don't want to rely on the inpatient staff to have to fill out reports every time, but collecting data on this is challenging without their reported experience.
Absolutely. And that I mentioned the patient conflict. It's a Len Bowers conflict and containment, which then relies on the charge nurse. And again, this it's on my bib, Joanna Inako's study, where she used a clicker. Is also on my bib. And any of you that don't have access to a library and want a copy of this, although you have a librarian, so you probably do. Any rate, I think that I'm really glad you asked that question, because we need different methods to really collect the data. And I think that I think we need to think more. I'm just thinking we need to think more about that. And you can use a SOAS-R, but it's hard. You can't put more burden on staff. I think the patient conflict and containment scale is one method. Mm-hmm.
Absolutely. So, Dr. Katzman, there's a comment from Lorraine.
Mm-hmm.
I'm pronouncing it correctly, Lorraine Donner. And Lorraine indicated, please remember that nurse-patient engagement in the therapeutic relationship is not a new approach. It goes back to the very beginning of psychiatric nursing.
Mhm.
But developments along the way have made it more difficult to apply these approaches intentionally, as Dr. Delaney suggests.
Absolutely. Well, that's absolutely true. It is. You know, I always love this quote by Susan McCabe, that the relationship is not what we do, it's who we are. And of course that's true. We wrote a paper a while ago, my colleagues and I at APNA, called Safety Engagement. I don't remember the title of it, but it was really hard to find research on the relationship of engagement and safety. So that's why I'm thinking that this tool, you know, once we could measure trauma-informed care, we got a lot more literature on the relationship of trauma-informed care and restraint. So I'm hoping that if people start taking engagement, perhaps a DNP project, and using this engagement tool, we can start seeing more of the relationship of engagement and safety.
Great.
Agree.
Last question here from Dr. Robert Kassoff, who says it's an interesting idea. Not measuring threat levels, or not measuring threat leaves a big hole in the data. An event can occur, but handled so that it de-escalates to the point of no incident. So because of good professional intervention, nothing ever happened.
Mm-hmm. That is so absolutely true, and it's like the holy grail to how we're going to capture prevention. That's why again, the clicker study in a way would capture what you prevented. Even if you did it for a week, it would capture what you prevented. Otherwise, I think it's going to be difficult to capture what we prevent. Absolutely true. Absolutely true.
All right. Well, thank you.
Oh, well, thank you.
Delaney,
Boy, this has been so much fun. Thank you so much for having me and my friends in the audience. Thanks for writing those good things.
Yes. Yeah, really
And
amazing
it's been
comments.
my pleasure.
No, thank you. What an inspiring presentation. And Dr. Khan, thank you for the partnership today and at work here at Silver Hill. And to everyone joining us today, and a happy Nurses Week. And as a reminder, for those wishing to receive continuing education credits, please go ahead and complete the evaluation survey that will automatically show in the browser as we end the webinar. And again, we hope you can join us on May 22nd for the presentation from Dr. Claudia Gold. And here we've been talking about engagement and connection, and now we're going to disengage and all be on our own, for those who happen to be in the Martin Center. So thank you. Thank you so much. And great to know you.